Marilyn J. Siegel. I'm from the Mallinckrodt Institute of Radiology, which is in Washington University School of Medicine in St. Louis, Missouri. And the topic that I'll be discussing will be chest sonography. Okay, so we're going to discuss chest ultrasound. And the objectives will be to discuss the technique of chest sonography, describe normal anatomy, and then review the imaging features of common chest lesions. Let's start with the technique. If you're doing chest sonography, you want to use a small footprint sector transducer because it's best to insunate the ribs and above the suprasternal notch. A linear array transducer is best for chest wall lesions to look at the peripheral lung and pleura. For near field structures, you should use a higher resolution transducer, 7.5 to 10. And for deeper structures such as lung or mediastinum or larger patients, 5 megahertz will suffice. There are a number of acoustic windows, and you've got to know these to do successful chest sonography. The supraclavicular window is labeled number 1 above the clavicles. Suprasternal is 2 above the sternum. We can use a parasternal window denoted by 3 that can be done on the right or left side. 4 shows the transsternal window going through the sternum. This is particularly advantageous in the neonate. 5 indicates an intercostal approach which can be used at any age to look at the pleura and peripheral lung. 6 is below the xiphoid process, and 7 is subdiaphragmatic. 8 is a posterior paraspinal approach. So why do we want to use these? What's the rationale? The supraclavicular, great for looking at lung apex. Suprasternal gives you a wonderful view of the upper mediastinum and great vessels. The parasternal, which can be right or left, is an excellent way of looking at thymus, ascending aorta, and the right pulmonary artery. Transsternal, the sternum, you can use this in the neonate and infant. Easy way to look at the mediastinum and the thymus. Intercostal works at all ages. We can look at the pleural space and peripheral lung. The subxiphoid, below the xiphoid process, and the subdiaphragmatic, below the diaphragm. It's the best way to look at the lower lung and pleural space as well as the diaphragm. And then along the spine, paraspinal approach, good for posterior masses. So we know how to do this. Let's look at some normal anatomy. One of the structures that you should see in infants and neonates, in fact in the first few years of life, is the thymus. It is a soft tissue structure. It has a quadrilateral or rectangular shape, smooth, convex, or straight margins. The arrowheads point to that. And the characteristic finding of normal thymus and the clue to the diagnosis are these regular linear echogenic densities throughout. So let me, this skipped ahead. Let's go back to this. These linear regular densities throughout the thymus, and here you see the quadrilateral shape. Thymus changes with respiration, and it lives in front of the vessels, and this is the superior vena cava. Another normal thymus, transsternal approach. In a neonate, we put the transducer over the sternum. Here's the cartilage. We can see the thymus denoted by the caliber marks. It's quadrilateral or rectangular. It's got these fine linear echo densities, and it lives in front of the vessels, the superior vena cava and aorta. If you put color, you see flow in the vessels behind the thymus and some flow in the thymus. Okay, let's look at normal pleura and parenchyma, other normal findings. The pleural lung interface is hyperechoic. It is this white line that we see, this echogenic white line. Anterior to the white line, we can see the normal hypoechoic black cartilage. In front of that, muscle and soft tissue. Behind the pleural lung interface, we have aerated lung, which is echogenic, but not as bright as the pleural lung interface. And very typical of aerated lung are reverberation artifacts, deep to the near field, deep to the pleural lung interface. These are these white linear lines we see, and this is a blown up image of that. You can see these echogenic lines are at very regular intervals, and in between we see air-filled lung. Another normal structure, the diaphragm. It is a smooth, slightly undulating echogenic line. This is normal liver with hepatic veins. This is the diaphragm. This is the transverse view, and on the opposite side, the long view, the echogenic diaphragm. Here's liver and kidney, and on the other side is aerated lung. And finally, we should see vessels. That's another normal finding. So you can see these through a suprasternal approach. Anteriorly, we have some thymus, and behind that, superior vena cava and the aorta. Okay, now you should understand the technique in normal anatomy, and let's look at imaging features of some common chest lesions. So what are the indications for chest sonography? Number one, and perhaps the most common, is evaluation of pleural effusion, the character and extent of the effusion. Another indication is looking at a peripheral opacity on the chest x-ray. The question is it parenchymal or pleural disease? A third indication is the abnormal mediastinal contour, particularly in neonates and infants. Is it thymus or a mass? Fourth indication, we use it for congenital lung anomalies, particularly sequestration. And the final indication is evaluating an abnormal diaphragm. Let's start with pleural effusion. Most effusions are parapneumonic and related to an infected lung. So the important question, the decision that needs to be made, is this a simple serous effusion, or is this a complex purulent fluid? Simple effusions appear anechoic and change shape with respirations. The complex purulent fluid are echogenic. And why is it important? Because simple or anechoic fluid is usually amenable to aspiration. In fact, that's all you may need. And conservative management. A thoracostomy tube may be placed for drainage, but you don't need to give additional fibrolytic therapy. Complex effusions, empyemas, are not a contraindication to percutaneous drainage, but their presence often suggests that a catheter may be needed, or the catheter may stay in place for a longer time than that associated with a simple fluid. In addition, complex or purulent effusions may need fibrolytic therapy. So this is a simple effusion. Transverse view, the fluid's anechoic. Here's the echogenic diaphragm in the kidney. And if you add color, you see color flow in the fluid. Okay, a sign that it's mobile. Simple fluid, this should respond to either putting a needle in and aspirating the fluid. Perhaps a catheter is needed, but you don't need to give additional therapy. Here's another one. Here's simple fluid, it's anechoic. You can see it around this collapsed atelectatic lung. It's beneath the lung, it's on top of the diaphragm. Here's the liver. This is a catheter that's being placed. You see the tip of it. The catheter is advanced. The fluid collapses completely, and now you can see some aerated lung beneath the catheter. On the other hand, these are complex effusions. This has a lot of pus in it. Here is a fluid with echoes. Adjacent to it is some consolidated lung. Long axis view here is showing the diaphragm, echoes in the fluid, consolidation or pneumonia. A couple more effusions. This has got a lot of septation in it. Next to it is pneumonic or consolidated lung, and long axis showing septated effusions. Why do you need to recognize this? Because these effusions will need a catheter in place for a longer time than a simple effusion, and they may need additional fibrolytic therapy. A second indication for ultrasound is evaluation of opaque hemithorax. So the question is, you want to separate an effusion from atelectasis or consolidation. We know what fluid looks like. What does atelectasis and consolidation look like? They will transmit sound, unlike normal lungs, so they'll be echogenic. Other findings in consolidation, you can see bronchi. They can be air or fluid filled. As a rule, you won't see much color flow in consolidated lung. And with atelectasis, you probably won't see bronchi, but you will see flow because perfusion is maintained. A couple of examples of bronchograms. Long axis view, here's fluid, here's the diaphragm. And this echogenic area is pneumonia, consolidated lung. The linear black areas are fluid-filled bronchi. Here's another one, fluid around the lung. The lung's echogenic, and the bright linear areas, air bronchograms, air within bronchi. Bronchi and echogenic lung means consolidation or pneumonia. Here's another one, transverse view. Here's the diaphragm, liver, this echogenic area, which is slightly hyperechoic to liver, fluid-filled structures, tubular structures, pneumonia. And this is atelectasis. Here's the diaphragm, liver, long axis view, an echogenic area, and now you see vessels in it. The vessels are crowded together, no bronchi, atelectasis. Third indication for ultrasound, abnormal mediastinum, particularly in a neonate or infant. Is it thymus or is it a mass? Now, most of us don't do sonography routinely for evaluation of the mediastinum, but in the neonate it can be useful and provide a diagnosis. So here's the question. If you suspect an abnormal mediastinum, is it thymus or is it a mass? This is a neonate, has a cough, gets a chest x-ray. So-called double density in the right upper hemithorax. We see two shadows. Ultrasound's great. You can do a parasternal or transsternal approach through that. Here we are. Here's a structure that's echogenic, has linear echoes throughout it. This is normal thymus. There's no mass effect. You can see the vessels behind it, typical of the thymus. What about this one? Another neonate with a cough. Double density, two shadows. So let's do ultrasound. We can use parasternal, transsternal, and in this case, long axis view. Here's some cartilage. It's a cystic mass. It's a cystic mass in the mediastinum. This turned out to be a bronchogenic cyst. How about this patient? There's a mass, or at least increased density, in the left upper chest. Trachea is deviated to the right. This almost looks like pneumonia. Maybe this is pneumonia, or is it a mass? Ultrasound's done. This is a large mass filling most of the chest. There's some very bright echoes. They're not scattered homogeneously through the structure. This is not thymus. These bright echoes represent calcifications. This is neuroblastoma. It's a solid mass. It has mass effect, and the CT shows this posterior mediastinal mass. One more. This patient had a mass around the lower spine. Here's the heart. Transverse view. Here's the heart. We can use it as a window. The spine's back here, and in front of the spine, there's the aorta, and it's surrounded by a complex mass that has some fluid and some echoes. So this is a complex multilocular mass. MR is done. It's filled with fluid. This is the mass surrounding the aorta. This is typical of lymphangioma. Ultrasound's a great way to look at masses in neonates and separate masses from thymus. The fourth indication for ultrasound, congenital anomalies. No, most of the time CT and MR are done. But ultrasound can have a role in pulmonary sequestration, particularly in neonates and infants. So what's pulmonary sequestration? It's a mass of lung that has no normal connection to the airway or pulmonary artery. There are two types. Extralobar has its own pleural coverage. This is normal lung. That's the extralobar sequestration. It's shiny because it has pleura. It drains to systemic veins, usually the azygous vein. It's supplied by an artery off the aorta. Intralobar sequestration does not have a separate pleura. It often becomes infected. You can't separate it from the remaining lung. It has arterial supply also from a branch from the aorta, but it drains to pulmonary veins. So what's it look like? On ultrasound grayscale, it's echogenic. It's a mass. If it's above the diaphragm, it's probably intralobar. If it's below, it's extralobar. Does it really make a difference if you separate the two types? No, but you can do it, and sometimes it's helpful to the surgeon. But the major job for the sonographer is to identify the sequestration. Doppler ultrasound will confirm there's an abnormal artery off the aorta. We're not as good at looking at the draining vein with ultrasound. We need CT or MR for that. So here's an infant with recurrent pneumonias and density on the chest x-ray in the lower left hemithorax. Recurrent pneumonias, we think of sequestration. Ultrasound's done. Here is the diaphragm, that white line. Above the diaphragm, there's an echogenic mass with a vessel in it. Sequestration, to confirm it, put color on. Here we have the aorta, and you can see this feeding artery going to the area of the sequestration. The artery's in red. In fact, in this case, we can see a little bit of the vein in blue. How about this one? This is a newborn who had a mass in utero seen around the diaphragm on the left, and on the chest there's a little tinting here. That's the mass. Ultrasound's done. Long axis. Here's the spine back here. Here's the kidney, and there's a mass in front of the kidney or on top of it. Put color on. Here's the aorta, vessel going to the mass. Pulse Doppler shows arterial flow, vessel that's an artery coming off the aorta, sequestration. And the CT shows that same vessel coming off the aorta and the sequestration. And one more, another neonate with an in utero mass, long axis view of the spine, part of the heart here. Here's this mass below the diaphragm. This is the area of the diaphragm. Here's the spleen, the mass. You put color on, you see flow in the aorta and a feeding vessel going to this echogenic mass, sequestration. The final indication for ultrasound would be evaluation of the abnormal diaphragm. And the question is it a hernia, is it eventration, or paralysis? Hernias, most of these in children are the so-called Bochdalek hernias. These live more commonly in the posterior lateral chest on the left side. Morgagnia or anterior herniations, they like the right side, although either of these hernias can occur on the right or left side. So what do you see on ultrasound? You see interruption of the normal linear diaphragmatic echoes and abdominal contents in the chest. Okay, this is a neonate on day 1 with respiratory distress, and we see increased density in the left lower chest with a few lucencies thought to be bowel. So an ultrasound's done because a hernia is suspected. Long axis view, this is the back of the chest, and these echogenic areas, and they moved at ultrasound, bowel going into the chest. Here's some aerated lung in front of the bowel, Bochdalek hernia. Here's another newborn with respiratory distress, and the right hemithorax is nearly totally opacified. It's displacing the heart and the mediastinum to the left. Little lucency, maybe it's bowel, maybe it's lung. Ultrasound's done. Sagittal view, here's the back, here's the front, here is the liver and the abdomen. This is the area of the diaphragm which we don't see. This is liver going into the chest and lung in front of it. This is a Bochdalek hernia. How about this patient? An infant about a month of age, comes in with a cough, has a bulge on the chest x-ray here in the area of the right hemidiaphragm. Lateral view shows some increased opacity behind the sternum. Is this a hernia or is this an eventration? Sagittal ultrasound, and this is a case that George Taylor nicely loaned me. Sagittal ultrasound, anterior part of the chest. Here's part of the diaphragm, it's interrupted. You see the liver, this is in the abdomen. Here's the diaphragm. Anything below this is in the abdomen. We don't see part of the diaphragm here. The liver goes into the chest. It goes anteriorly. This is lung behind it. This is an anterior hernia, a Morgagnia hernia. What about this infant? Has a bulge in the left hemidiaphragm. Hernia or eventration? Do ultrasound. You see the diaphragm, it's intact. You can follow it all the way up. There's a bulge in it. This is an eventration. An eventration is a weak or thin diaphragm. And ultrasound, instead of the normal straight diaphragm, you see a bulge, and beneath the bulge you see liver on the right and spleen on the left. And the final diaphragmatic abnormality is paralysis. So this patient is having some respiratory difficulty. The chest showed the hemidiaphragms at different levels. Transverse view, here's one diaphragm, here's another diaphragm, right hemidiaphragm, left hemidiaphragm, liver going across, here's the spine, the aorta, diaphragms, the hemidiaphragms at similar levels. Expiration, the right is back here, the left hemidiaphragm has moved anteriorly. This is paralyzed, the right's paralyzed, it's not moving, the left is moving. So diaphragmatic paralysis. So in summary, I think ultrasound's a great way to image the chest. What I've tried to show you are the techniques of doing this, normal anatomy, you have to understand that, and then some of the common indications. Ultrasound has a role in the neonate, particularly in looking for masses and separating them from the thymus. At all ages, it can be used to look at pleural effusions and consolidation, the diaphragm, and some other abnormalities such as the vascular abnormalities or even sometimes cartilaginous abnormalities. And at that point, I'll stop and thank you for your attention.